Assalamu alaikum everybody. Before some more people join and we start our discussion, uh, if you just notice the topic or the motto which I have in this discussion, would you like to comment something? Any one of you? Like, what is your point of view about preparing for any exam? Everyone can hear me? Arsalan, what would you like to say?
Sir, nothing, sir. I have also some query.
Can you speak a little louder?
Yes, sir. I can hear you well.
Yes.
Sir, I have a question about myself and about my training, and I need some suggestion from you. Can I ask?
You have to be a little loud because your sound is coming very low. If you can bring your mic a little bit closer to you so that we can hear you.
Sir, can you hear me now?
It's better now. Yes.
Sir, I have some my issue, so I can discuss it from you. So can you allow me?
Yes, so please start to save time.
Sir, actually I am doing my training in private institute in anesthesia, but recently I have a choice to get some points from BSU and after 6 months or 1 year to move government setup. So what should I do?
Time is money. If you have started your training and your workplace is satisfactory, you should not waste time. Okay?
Okay, sir.
Okay. We can discuss this thing. You can call me anytime. Okay. So if we just think about what I have written in the topic, that actually whenever all of you are preparing for any exam, you are thinking that there is something out of the world for any specific exam. This is one thing. And the other thing is that people think that there is difference between written MCQs, Viva, SAQs, oral part, long case, short case, OSCE. There is so much confusion among the people. They try to segregate the preparation. Okay, and then what happens that they are not able to find the clue. What is the distinction? What is the domain of certain thing? And then above average students have no problem because they will be able to cover the thing in whatever way they are doing it. But because the majority people who suffer are the people who can do a little better, but they are unable to do it because of this distinction. That some people say that this is for Viva, just first get rid of the written part and then you should be preparing for Viva. And this never happens. So my point of view and my request for all of you that if you prepare a topic in a way that you cover all the aspects, when just what you say, nip the evil in the bud. Okay, so this is the point of view which I want you to learn, that whatever exam is, whether it is a Pakistani exam, whether it is Indian exam, whether it is UK, British exam, Irish exam, the same thing which is the common is anesthesia. If you are appearing in written exam, this is also for anesthesia, and if you are appearing in oral part, this is also for anesthesia. Unfortunately, people don't understand this thing, and they think that this is something out of the world. So, and this is one thing. The other thing, which is the reason for this distinction, that people try to have a shortcut. They don't want to work hard. They don't want to prepare themselves in a way that they are able to, whatever sort of exam or whatever source of challenge they have, they will be able to answer it. So this is the real problem. And the best way to cater it is that whenever you are asked to prepare a topic, you should be thinking that what can be the possible questions which may be asked. So I give you an example of, for example, thyroid, which is being asked in any sort of exam, whether it is Pakistani exam or any part of the world, whether it is Africa or Asia or Australia or England or America, thyroid they will be asking you, because there are so many aspects of anesthesia which they can ask you in this topic. Okay, similar is diabetes mellitus. Similar is, for example, patient with the heart problem. Okay, so in this one topic they will be able to ask you a number of concepts. So the best way, for example, for thyroid, that whatever book you will read, pick it out. I am sure that the thing which I'm going to tell you will not be covered in one book. Like, for example, first of all, you should be starting from the surface anatomy of thyroid, where thyroid gland is located, what are the corresponding level to the spine, what are the correspondent level to the tracheal ring, what is the structure, what are the lobes, what is the isthmus, and then next step will be the functional anatomy, like what is the arterial supply, what is the venous drainage, what is the nerve supply, and then you go into the histology, how is the structure of the thyroid gland, how the thyroid hormone is synthesized, what are the factors which control the thyroid hormone. Okay, what is the role of thyroid hormone releasing hormone, what is the role of thyroid stimulating hormone. So in that way you will be able to understand what is the concept. Otherwise, if you are targeting it in some other way, you will not be able to pick it, and you will not be sure the question, some question will come and you will not be able to answer it. Okay, so this is point number one. Then you will be going towards the sign and symptoms related to thyroid problems. What are the causes of hyperthyroidism, what is the symptoms and sign of thyroid hyperthyroidism or hypothyroidism, and then you go into the pathology, and then you go into the correlating medicine, that what are the coexisting problems. Then you will be covering the topic in the whole way. This is the same thing which is being asked in any sort of exam. Okay, this is one part. The other part is that whenever you are being asked to anesthetize a patient, there will be two scenarios for any patient. Like, one will be that surgery or thing related to that specific problem, or a patient with that problem for any other surgery. Okay, so whatever scenario will be, you should be focusing in the same regime, that you should be knowing that what is the basics of anesthesia care. I will be showing you some I have just made some, like, not slides in a formal way, but I have chalked out. Some of the people who are in touch with me know those things, that what are the common things which you need to focus in any case for anesthesia management, starting from preoperative assessment to the post-op. So this is what you have to be focusing. Okay, so this is the common approach you should be doing. Just let me show you something. Just give me a second. Okay, if, like, for example, we started with the example of thyroid, or topic of thyroid, and then we focused in that way, and then we reached up to this moment. Okay, so this is the common things which you need to ask by any, from any patient for any case when you are actually dealing it, is the preoperative assessment. And some of the questions will be separate, but majority of the questions will be common. Like, or if you are preparing for some other board of exam, like, you will not be dealing with the patient actually, but the things should be in your mind, that some things will be related to the demographic of the patient, like what the patient is, what is the age of the patient, what is the sex of the patient, what is the profession of the patient, what are the things which are related to the people who are for any international exam, and what are the racial or any genetic predisposition and specific group of people you are facing in any specific area. Okay, so these will be related to the, like, personal habits, like smoking or any personal habit. Then there will be something related to the comorbidities, like other than the disease itself. Okay. This will be in detail that you have to look at all the systems, the cardiovascular system, respiratory system, neurological system. Not everything will be in every patient, but this will be a heading which you should be knowing. While first heading is demographic, second heading is the disease itself, and then the comorbidities. Okay. And then will be something related to the surgery. Surgery we will be discussing a little bit in detail, but there will be that, like, is there any previous surgery? Is there any problem with the anesthesia? Is there any problem with the airway? Is there any problem with anything, any allergy, any history of blood transfusion, or anything related to it? Okay. And then you will be going on the symptomatology, okay, of that specific disease. And then you will be chalking out some, like you will be looking at some signs, and then on the basis of overall, like, demographic history examination, and then you will be thinking that what investigation you need to do, and though what that investigation, what is the aim from that investigation, and how will you interpret on how will you using that investigation, because investigation is not for the people use this word routine, baseline. There is nothing, no concept in academic forum that you are saying routine. What is routine? Routine is nothing. You have to be focused. You have to telling the reason why you are doing that investigation. Okay. Then like I'm trying to go step by step. Then history, examination, investigation, and then you can use this word evaluation. And on the basis of that, you are able to find out risk factors, like what are the you will be able to see what are the pulmonary risk factors, what are the renal risk factors, what are the cardiac risk factors, what are risk factors related to any specific positioning, what are the risk factors related to any specific surgical step. Like if we discuss something in detail about surgery, that usually whenever we are dealing with any surgery, we first of all we see whether the surgery is urgent, whether the surgery is emergent, whether the surgery is elective. Anyone wants to say something? Okay. Whether the surgery is emergent, urgent, elective, or planned. Okay. Usually planned surgery and elective surgery come in the similar heading, and the emergent surgery and urgent surgery usually are counted in same heading, but actually there is a difference, that emergent surgery is to be done within minutes. Urgent surgery is to be done within hours. Planned surgery that you can plan for some time, but you have to do it. And elective surgery, there is no urgency, you can do it at your ease. So like for example, if we just translate into an example, so example of emergent surgery is firearm bleeding patient. You have to manage it, otherwise patient will die. Patient with fetal distress, fetal bradycardia, you have to proceed immediately. So these are the example of, and then you come to urgent surgery, like for example, obstructed inguinal hernia. Between obstructed and incarcerated, it will be, one of them will be emergent and one of them will be urgent. And then similarly, this one, appendicectomy or intestinal obstruction, these are all examples of urgent surgery. Okay, there can be debate that actually in books you will find both of them together, but in real sense you can dissect a little bit. Similarly, is between planned surgery and elective surgery. Example is all the cosmetic surgery, joint replacements are elective surgeries. Okay, and the surgery like for example cholecystectomy, it's an example of planned surgery. You cannot delay it forever, and but you can plan it accordingly. Okay, so this is one thing. Then the other thing is the risk of surgery, that whether the surgery is high risk, intermediate risk, or low risk. Then you will be considering the positioning, in which position surgery is going to happen. Then you will be thinking that any critical step in that surgery, like for example, if you are dealing with any vascular surgery having clamping and cross clamping and unclamping, then that will be a critical step. If you are dealing a surgery there are chances of any mesenteric stimulation, any vagal stimulation leading to bradycardia. If there is any surgery in which at a particular step sudden bleeding can occur, like bone cement implantation. This is the example you can see in every surgery. You can see that is there any critical step. There maybe there will be no critical step, or there will be some critical step. Okay. Can you mute, please? Can all of you mute your mic, please? If anyone wants to comment or ask any question, or he or she can raise the hand. Okay. So these are the things which is related to surgery. Okay. And then the next step will be, I'm trying to cover what I'm trying to give the message. The next step is that how different steps of anesthesia you will be covering it, like when to like on these basis you will be seeing whether you have to proceed or whether you have to cancel, whether you have to optimize, whether you get some other specialty help. Like example is that, for example, if there is an elective surgery and is the patient is wheezing, so you will be canceling the case, you will be giving some steroids, you will be doing some nebulization, you will be giving some chest physio, you will be doing giving some antibiotics, steroids, incentive spirometry, optimize if there is heart failure, you will optimize, you will give some treatment for heart failure. And when the patient is optimized, or you will be going for the surgery. Like this is a patient for COPD having some exacerbation, or in the form of this one bronchospasm, or any other symptom like that. So this is one example. If you have a patient with the anemia, you have an elective surgery, you will be postponing it, you will be building up, you will be trying to know the cause of anemia, then you will be treating it, and then you will bring it. This is the one example of optimization. Okay, this can be so like I'm repeating again and again so that you are with me all the time, that for any surgery, for any topic you are facing, you have to make the approach like that. We are giving example of thyroid surgery. We started from the surface anatomy, and then the physiology, and then the anatomy, and then the functional anatomy, and then going the how to monitor, how to control the thyroid hormone synthesis and its functioning, and then we go towards the pathology, what are the coexisting problems, and then we go towards the preoperative evaluation specific to thyroid. And then we will be thinking about how to optimize it. For example, if the word optimization for thyroid surgery will be if the patient is hyperthyroid or hypothyroid. Is there any coexisting thing which can be optimized? This will be like I'm trying to fill in the thing from which I started. Okay, so the next up till now, and then we will be focusing the steps of anesthesia. Like we need to continue, we need to give some pre-medication is one example. You are giving some anxiolytics, you are giving some decongestant, you are giving some anti-salagogue, you are giving anti-emetics, you are giving this one prevention of reflux or aspiration, you are giving some preemptive analgesia. This is all example of pre-operative, or you are converting long-acting medications on the in the short-acting. You are stopping some medication, or you are increasing the dose, or you are decreasing it. For example, patient was on anticoagulants or antiplatelets, you are modifying it. This all comes in the pre-operative, like pre-medication or optimization or control. And then you will be planning for airway control. You will be planning for induction. We will be considering what specific monitoring you need to do. Yeah, like any patient, you should be thinking whether it will be standard 1 monitoring, standard 2 monitoring only, or you are having some specific monitoring. Like for example, in some patients, you will have intra-arterial blood pressure monitoring, you will have cardiac output monitoring, you will have neuro monitoring, you are monitoring temperature, you are monitoring urine output, you are monitoring like neurophysiology, you are you are monitoring anything. So it will be a long, like you are monitoring, for example, CTG. This is something special. If you are monitoring ICP in specific conditions, this is something specific. So, and similarly, airway management. If you have some specific airway management plan, you need awake fiber optic, or you need kaleidoscope, or you need whatever. So this is one is airway management plan. Induction, whether you are giving IV induction or inhalational induction, and or for example, you have problem in monitoring, like in specific patients, you can have some challenging monitoring. You can have some problems related to IV lines in specific age group. Like if you are dealing with a patient, a pediatric age group, you will have this problem. Okay. Then similarly, there can be isolated thing, but this thing should be in your mind, that are there any preoperative challenges which you have, and then accordingly you will be planning what induction agent you will be using, which induction agent you will be using, which muscle relaxant you will be using or avoiding it. Then you will should have an analgesia plan, that are you using only IV analgesics, or you are giving some paracetamol, NSAIDs, opioids, you are giving some block, you are giving some local infiltration, you are giving some central neuraxial block, or compartment block, or peripheral nerve block, whatever. You should have a plan. Okay. Then you should have a fluid management plan, whether you are giving crystallite, whether you are giving colloid, whether you are giving some blood, whether you want some specific ingredients in your fluid management. Okay. Similarly, you should have a extubation plan, whether you want to extubate deep, whether you want to extubate awake, whether you don't want to extubate, whether you want to shift the patient to ICU, whether you want to have the patient HDU, whether you want the patient to be done as the ward case, whether you want to do patient as day surgery. So actually I forgot to mention this while preparation, but actually you should have a plan that where the patient will be going. So for example, again we go back to thyroid, that a thyroid patient, if there is long standing thyroid, big thyroid, and you are expecting tracheomalacia, then maybe you will not be extubating it. Or for example, when you are extubating it, you may have some problem and you need HDU for monitoring. So this is, you have to plan pre-operatively. You have to start some medication in post-operative period. You have to plan accordingly. So this is, I'm just trying to give an example. And when you will, if you understand this point of view, then you will be focusing or targeting any topic in that way. Okay. So any point, anything, any comment up till now? Please. Anyone wants any comment, or should I continue?
Sir, there is, if I may, I ask a question, sir?
Yes, please.
Sir, in our setup, usually this after thyroidectomy, surgeons say, okay, inspect the vocal cords. They are
okay.
Can you comment on, because if there is a damage to a vocal cords, so what is the fun of checking again? I hope you got my point.
No, I understand your point. But first of all, what are the ways? If you are asking ways, so first of all, there is a specific endotracheal tube, which surgeons are, it is not available in Pakistan, but it is available in some part of the world, in which there is an electrode, and actually they are monitoring the vocal cord movement throughout. This is one thing. Other thing is that you are not using muscle relaxant, and they are trying to identify recurrent laryngeal nerve, and they are monitoring it accordingly. Okay. First, the thing is that, like your question is that if they have identified a damage, then something else. But in most of the cases, they want documentation by you that the vocal, or it is for your safety. Even if they are not asking you, actually you should be for doing it yourself. Okay, because this will be a document. This will be a record that you handed over the patient in a proper way. Okay. Now the next step will be that how to do it. There are so many things there are so many ways to do it. You have to blunt the sympathetic response which you will be facing. Then you need the muscle relaxant effect to be worn off, because otherwise you will not be able to see it if there is a still residual muscle effect. Okay, so you have to do in a way that you have reversed the effect of muscle relaxant in any, if you have used it, Ideally, in some part of the world, if you have good opioids, remifentanil, fentanyl, or you are using some Tiva, or you are using some dexmedetomidine, actually you don't need to do it. But in our part of the world, we don't expect that any surgery can be done without muscle relaxant. Anyways, so make sure you reverse with the effect of muscle relaxant, and then you can do in a different way, that you can keep some inhalational agent, or you can give a bolus of lidocaine and propofol, and then you visualize it and then document it. Okay, you can, in some scenarios, you can record it as well. If you are using glidoscope and you are seeing the vocal cords moving, there someone can move the video as well. Okay, I hope you answered your question.
Okay, yes, and other point that procedure of doing it. Kindly correct me if I am wrong. So at the time of extubation, we will do the laryngoscopy and directly visualize the vocal cords moving with respiration.
Yes.
This is how it is done.
Yes, that's why you want the muscle relaxant effect to be finished. Otherwise, okay, if there is already muscle relaxation, so how can you monitor it?
Definitely, the vocal cords will be paralyzed and they won't.
And then the challenge, the challenge which you face in that time is because of this thing, that you have to reverse the muscle relaxant, and you have to still keep the patient in a way that he is not disturbing your laryngoscopy. Okay, so if you have glidoscope, you can see it in a better way, or video laryngoscope, you can see it in a better way. Okay. Okay, so okay.
Sir, what are international guidelines about extubating a patient with thyroidectomy regarding visualization of vocal cords?
There is no international guidelines. It is you have to keep the patient safety. You have to see it. Okay, there are things related to presence of tracheomalacia and this vocal cords. You have to see these two things. Okay, if there is chances of patient having tracheomalacia, then you should do a leak test. Then you should have a backup rigid bronchoscope with you. Okay.
Okay.
And ENT people should be on board. This is one thing. And if you are dealing with patient with suspected recurrent laryngeal nerve, and you are expecting this thing, then you should either keep the patient intubated, or you should, if for example it is in a way that you need tracheostomy, so you have to plan accordingly. Okay, so you should have a plan about it. Otherwise, visualization, make sure that this one vocal cords are moving, and in case of tracheomalacia, you have to do the leak test, that there is a leak. Okay, so yes.
Assalamualaikum. Sir, ये repeat करिएगा please. Tracheomalacia वाला और इसका difference.
You know, we will be discussing separately. We are I'm at the moment, I'm just trying to I have discussed this topic in detail in thyroid discussion. Okay, so because at this point of time I'm focusing in a way that we are able to identify how we should be targeting any topic while we are preparing it. Okay.
Okay, sir. Thank you.
The thing is that it is with the leak test, that if there is for example tracheomalacia, and you deflate the endotracheal cuff and there is no leak, it means there was leak before, but now there is no leak. It means that tracheal rings are collapsed now. Am I right? Do you understand, Hafiz Mohammed Wasim? Did you understand?
Yes, sir. Yes.
Okay. Okay. Yes, Dr. Awais.
Assalamualaikum, Zishan bhai. It's been such a long time since we spoke. How are you?
Maybe I'm not able to listen to you. Your voice is not coming at all.
Hello.
Can you be a little loud?
Can you hear me now?
Unfortunately, anyone else can listen. I cannot hear him.
Yes, very low voice quality, sir.
Can you hear me now?
Wes, if you can write down the question, I will answer you, because I'm not able to listen to you. We have to move forward. Okay. You just write down in the message, in the chat box. You can write, I will answer you. There is some problem, I'm not able to. Yes. Okay, Nasir, where is Nasir? Nasir has already. Okay. Okay, so that's what I was trying to say, that you have to focus any patient in that way. You have to prepare like this. This is, I have just tried to chalk out in this way, that you have to see what is the ASA status, what is the functional class, what is New York Heart Association class, if there is association with the dyspnea or heart failure. You have to see the Canadian class of angina. You have to see what are the any active cardiac condition. We are not focusing, we will be discussing in I have discussed this thing in detail. You can find it in the YouTube different lectures, you can find it, and we will discuss in separate setting. Okay, so this is the file of anesthesia planning, and you should be looking at these things for every patient, regardless whatever surgery you are doing. Maybe there will be no risk factor, but you have to make your filter in that way. Is there any active cardiac condition? Is there any clinical risk factor? Is there any pulmonary risk factors? If any cerebral risk factors, if there is any renal risk factors, you will be focusing accordingly. Is there, for example, if there is a patient female gender and the surgery is occurring of ENT surgery, in which there is some problem in the vestibular system, there will be more chances of PONV. Similarly, if there is a patient with the full stomach, there are chances of risk. Aspiration risk. Similarly, it will be if you have a baby or if you're an old man, there will be chances of hypothermia. So you have to look all these factors in every patient, and this is the common thing we should be focusing. And if you prepare your topic, whatever topic you are reading, with this background in your mind, that in every patient, in every disease, every surgery, every patient, you have to find if you have any of these risk factors or any of these challenges. This is what will make you prepared for that topic. Otherwise, if you are not able to identify, and you are at the book which you have read, you are not able to find that question, actually you will miss it. Okay, so this is, you will find it, it's available in the Google Drive link. Okay, so I actually discussed everything here which I have told you, and there are certain things which I have written it, that you have to, in every patient you have to keep normoxia, normocarbia, normotension, normovolemia, avoid sympathetic stimulation and stress response. You have to maintain the vital organ supply, especially cardiovascular and neurological, and then the renal. Okay, so you have to maintain sinus rhythm, we have to maintain SVR, we have to maintain preload and afterload, and this I will just mention it. Okay, so now come back to the point that if you are preparing for any specific exam. Okay, yes, Azhar, what you want to ask?
Sir, regarding active cardiac condition, is it what I understand, kindly correct me if I'm wrong, is it active ischemia going on, or congestive heart failure, or what else? Actually,
no,
is it
device? It is major cardiac predictors. Azhar, you should be starting taking some ginkgo biloba so that you don't forget these things. Okay, active cardiac conditions is also called as major cardiac predictors, and it includes acute or recent MI, unstable angina with class 3 and 4, decompensated heart failure with the New York Heart Association 3 and 4, severe valvular heart disease, severe arrhythmias. These are active cardiac conditions, or in some books it's written as major cardiac predictors.
Is it the same, they revise these criteria, cardiac conditions, sir?
Whatever you want to say. Okay, American Heart Association label them as major cardiac predictors. Intermediate are the clinical risk factors, which are one step down. Like here you have unstable angina, there you have stable angina. There is, you have decompensated heart failure, there you have compensated heart failure. And then additionally, there is insulin dependent diabetes mellitus, there is history of CVA, and there is renal failure with creatinine more than 2 or more than 2 milligram per dl or 176 micromole per liter. Okay. Okay, because now we already have consumed more than 30 minutes. So I just want to tell you that specific exams you are targeting. For example, if you are targeting exam in which there are MCQs, still you need the same knowledge. Yes, you need to practice a number of books in which you come across different sort of scenarios. But if you have these baseline knowledge of thyroid, I guarantee you that you will be able to answer any question. Like any question will be on the thyroid physiology. Any question will be on thyroid pharmacology, like what medications are affecting thyroid function. You may make a list of it. What are the medications which destroy, like if someone can ask, someone can answer this question. What are the medications which inhibit thyroid functions or disturb thyroid functions? Can anyone recall? Yes. Can anyone recall? Like one example is amiodarone. One example is radioactive iodine. It will destroy the thyroid function. There may be some other, I cannot recall some other medications. So you have to do like that. You have to do the brain exercise. What are the things which disturb the level of, yes, maybe carbamazepine. What are the medication which displace free thyroid, okay, by protein binding? Like if there is condition of hypoalbuminemia, there will be more free drug, more free thyroid hormone. This I'm giving you example. So you have to focus like that, and any question you will be facing will be among any of the points which we have discussed. Okay, so there is no question. The same things will be asked in the viva, in the oral part. There, because I sent this message to people who are also preparing for FCAI or any other international exam like EDAIC, there is only small difference between among the exams. Like if I just brief you about this FCAI exam, actually FCAI exam is more near to our traditional FCPS, which is being destroyed recently by the current, I'm sorry to be using this word, but actually the more way of converting it into MCQs is not correct at all. And anyone can challenge my statement, this thing, because this is premature. They did not build up as adequate standard pool, and they convert it into MCQs, and now people are suffering. Okay, this is one thing. Anyways, FCAI has the traditional pattern of MCQs, choose the best questions, 100 choose the best questions, and there are 10 SAQs. There are 10 SAQs on specific topics. There is a specific pattern for it. Like one of the question will be from ICU. One of the question will be from cardiothoracic. One of the question will be from gyneops. One of the question will be from pediatrics. One of the question will be from neuro or trauma. One of the question will be from regional anesthesia or pain. One of the question will be from applied basic sciences. Applied basic sciences including anything, physiology, pharmacology, anatomy, physics. Even if you are very unlucky, you can have a question on statistics as well, or research as well. This also is among the list of statistics. Among this list of applied basics. Okay, and then blood, body fluids. So this one question comes from either blood or any fluid management, any electrolytes, things like that. So this is a rough idea that one question will be from ICU, gyneops, pediatrics, neuro, cardiothoracic, applied basics, regional anesthesia, pain. Out of 10, this is, and there are some, maybe I am missing it, but 10 SAQs with specific, and you don't need to write in details. You just have to, these are actually, there is difference between SEQs and SAQs. SAQs is short answer questions, and SEQs is short essay questions. So in essay question, you need to write a little bit more and they are more comprehensive. But here, you just need to be very specific. You can make even points you can make use of bullets. And because now this FCI exam is occurring online, so you just need to type. Okay, you can type, and you can like, you don't need to write in too much detail, grammatical or thing like that. Yes, of course, the spelling should be comprehensible. If you are writing spellings in a way that they are not able to understand, that maybe they will not be able to give you credit. So this is one part, like written and MCQs. I think 3 hours each, or 2.5 hours, they will be giving me the instruction. I have discussed, because I did not appear in the Irish Fellowship exam in this current pattern, which is totally different from which we did. It was much more difficult, challenging, because you need to go there, you need to have the visa and everything. But now with online, you don't need to do, but still they are observing you. You cannot do copy paste, you cannot cheat, you cannot do like that. You cannot go Google search to find the answer. It's not possible. Okay, so this is one thing. And another thing is that the oral part, in which there used to be one big clinical scenario. Like, I will give you an example. It will be just like which we do in our part of in FCPS long case, that they are giving you a data. Like the patient which I had, similar patient most of the people get, is like, one scenario will be that there is a 55-year-old male, known case of von Willebrand disease with morbid obesity, known case of diabetes and hypertension, presented for laparoscopic hemicolectomy for CA colon. Okay, 55-year-old, morbidly obese, known case of diabetes mellitus, hypertension, and von Willebrand disease, presented for laparoscopic hemicolectomy due to CA colon. This was my scenario, and I actually failed in that part at that time, because I did not have the multidisciplinary team, and I did not attend anything about von Willebrand disease with the hematologist. I told everything, but I failed, because at the end, when I was about to stand up, he said, "Would you like to consult hematologist?" So I knew at that time that I failed. Okay, so this is, I'm giving you one example. They give you all the data about the possible history, examination findings, investigations. They ask you about ECG, they ask you about chest X-ray, and then they will be asking each and every step, like, what are the challenges in obese patient? How will you control the blood pressure? How will you control at what blood pressure would you like to cancel the case? And things like that. Okay. This is a long case. This is 15 minutes, 20 minutes, just like our long case, but all the data you will have. Now they have changed it into CRQs, constructive response questions. Constructive response questions. Okay. They have converted the oral part also in the written. Like, they will be asking you the questions and you have to answer them. Like in this, after giving you this scenario, they will be asking you what are the risk factor, how will you control this thing, what are the findings in ECG. They will be showing you ECG, they will be showing you X-ray, it will be written what are the findings, and you have to write it. Okay, so now actually I will use the word, it's loot sale. And now if you have the concept and you have prepared yourself in a way that you know how to interpret, and the way which I have told you, please, I request you humbly that please target the studies like that. If you're trying to have a shortcut, oh, I'm going for MCQs, I have 100 questions pool, I have 1000 question pools, and this is from the current paper, and this and that, and yeah, I will cover, I will ratify, I will cram the answers, and I will pass. Remember one thing, there is one thing, there is no shortcut to glory. I tell you, even if you pass the exam by this way, next step will be coming the oral part, and then you will be caught. And for example, even if you are able, very smart, and you pass the exam as well, what will happen then when you are dealing with the patient, you will regret that why you prepare, why you didn't study in a proper way. Then another thing is that when you will be becoming a consultant, and there will be a resident with you, and if he is asking you something and you are not able to answer, the embarrassment which you will face at that time, you cannot imagine that one, because I am at that stage. And if someone asks me any question, if I am not able to answer, if you are a sensitive person and if you are really committed, you will feel embarrassed. Okay, and you can imagine the comments which you are doing it at the moment for your seniors or your colleagues. If they don't know anything, when he's leaving the place, you are saying, oh, he doesn't know anything. Or there are people, I remember that there used to be some of my seniors, if I'm asking them something, they say, please read and tell me as well. This was used to be the response which I used to get. Okay, and I know that they don't know it and they are not able to answer it, and then they are just running away from answering. Okay, so please, if you want to do that, then another aspect I will tell you, that you will never expect any of your family member to be anesthetized by a person who has passed the exam in that way, will you? So why you want others to do like this is against the basics of humanity or basics of religion, that you are trying to find a shortcut, pass the exam, and you are dealing something very serious. Any other specialty is not comparable to anesthesia. I love anesthesia more than I used to do yesterday, because it's such a beautiful specialty. If you are not able to cope up the challenges, because every day you will find something new, every day you will find something challenging. Okay, and it's beyond the books. So this is my message. Please don't find shortcuts. Don't try to cram the answers of the so-called tools you get. Don't ask anyone what are the previous questions. Previous questions should be for practice. Previous question should not be that you are able to find the key, a duplicate key to open the lock. It should not be like that. This is against our basic medical science. This is against any rule of humanity. Yes, you will say that you have passed the exam, that's why you are saying like that, but I failed number of times, and I know that if you are I passed in the written part easily, and then I was stuck in the oral part, because actually the day I claim this word again, please, I will be very slow in telling you, the day when you have written part, if you are taken for the oral part on the same day and you are able to pass the oral part as well, I guarantee you, you will not fail in written part that day. If you have a preparation in a way that on the day of your written part day, you are able to pass the oral part, if it is taken in the same day, I guarantee you, you will not fail in written part that day, because this shows that you have the grip on the subject. And if they are asking you from alpha angle, beta angle, delta angle, you are able to answer it. Okay, so this is my request, that cover the topic in a way that you are able to answer it any way, whether it is FCAI or whether it is EDA. So FCI, I will, because I just got distracted a little bit, I will finish. Arsalan, I will answer your question in few seconds. FCI, I again repeat, there is one MCQs part with 100, choose the best questions. Then there are 10 SAQs. Usually MCQs are, some of them are on the basis of some guidelines, on the basis like you will find the clear answer. It will not be confusing. This is one thing. And the aspects which are not being covered in the theory part, they will be stressing on them in MCQs part. This is general rule. Okay, and then you have oral part having one long case with the long scenario and two tables. It used to be two table vivas, but now they have changed pattern a little bit, and they are taking some CRQs. They are telling you some scenario, you have to respond. Okay, that what will you do if there is a bone cement implantation syndrome? What happens if there is air embolism? What happens if you have a pregnant patient with the who went into cardiac arrest? How will you anticipate things like that? I'm just giving you an example. Okay, so this is finish of FCI. EDA, people are very interested in EDA. One more thing about FCI, people ask this question: do we need to be registered from Irish Medical Council? Do we need to do OET or IELTS to appear in FCI? No, not at all. It has nothing to do with FCAI. Okay, so this is one thing. And another thing is that the advantage of FCAI alone is nothing. If you have done some post graduation and you are doing FCAI, or if you are working in Ireland and you are like focusing on equivalence pathway, because there is no training in Ireland, you cannot get training for non-Irish people. There is no training. So actually there is no advantage of FCAI. If there are people I came across who have done some diploma, who have done MCPS, who have done DA, and they are asking, please let me do some foreign examination, foreign degree, and I will become a big consultant on it. Please clear yourself. FCAI is not an exit exam. FCAI is nothing. If you are thinking that you will become a big consultant only by passing FCAI, it is nothing. In our country, in the majority part of the world, the way is separate. You have a training and you have an exam. In Pakistan or India or majority part of the world, we have an exit exam, that we are finishing all the requirements, all the prerequisites, all the research, dissertation, synopsis, intermediate module, whatever. Okay. And once we have all the requirements, then we are appearing in the exam and then we are passing it. That is giving it as an exit degree. So FCAI is not an exit qualification. MCAI, which is the first part of FCAI, some of the people are doing it while in Ireland, who are doing rotations over there. They will find some way to become consultant, but there is nothing like training positions which are being offered straight away. There is nothing like that. Yes, what are the advantages of FCI? It will give you a big knowledge. You will be able to handle your situation in much better way than before. Okay, like if I give you an example, but I got it from there. I'm able to talk in front of you only on the basis I faced international examiners. My arms were twisted, my neck were twisted by them. I handled the pressure, and now the result is in front of you. Okay, so this is the advantage. But if you ask me that someone is working in Pakistan doing MCPS training and he is asking, I don't want to pass MCPS, I'm unable to do it, and I have appeared in FCPS part 1 5 times and I'm not able to pass it, but now suddenly I will change my genetics, I will change my gender, or I will become something out of the world and I want to do this international exam. Please have mercy on yourself. If, for example, number one, if you are not able to pass the exam, it's not the responsibility of the college. It's your responsibility, because so many people who pass don't have anything extra or special than you. The only day is that they are able to satisfy the examiner, they are able to have the command on the exam. Yes, there can be some they are able to do it without any effort. There will be very rare people who will be able to do it. Okay, so if you are in Pakistan and you are trying to do FCAI without appearing in MCPS exam, or without passing FCPS part 1, you are thinking that you will do FCAI and you will become a big consultant, please, it's a big no. Please ask someone to spray some virtual thing or something, so that the Satan which is distracting you run away and focus on the primary degree. Okay, so this is my message, this is my request. For the other people who are listening, other nationalities, the situation is different. If you have finished your basic degree, then you should be doing it, and then you will get some advantage. Because what will be the advantage? You can get registration into Irish Medical Council or even GMC UK, General Medical Council. If you have done FCAI, you can get registered with General Medical Council or Irish Medical Council. Okay, so this is the advantage of doing FCAI or MC in that way. Otherwise, it's useless. This is one thing. EDAIC. Some people from Egypt, they have got the exemption. They can appear in the EDA. Some of the people in other countries, they can also appear in EDAIC. But Pakistani people, I mention it, the people who have not done FCPS are not eligible to appear in EDAIC. They can appear in EDA part 1, but they are not eligible for part 2. So either they need to have FCPS or I have heard that some people who have done MS from Pakistan, they have also contacted the European Society of Anesthesia, and they have given permission to appear in EDA, that they are eligible for EDA Part 2 as well. But anyone who has done MCPS or DA are not eligible for EDA IC. Their eligibility is exclusively for FCPS or MS in some isolated cases. It's not mentioned over there. Okay. This one thing, and another thing is that EDA is separately, even it has no words, even as compared to FCA. It is almost similar. Part 1 is having MCQs, and it is not our UL pattern. It is true false. So actually it is very easy and it is very difficult. What is the difference between true false and choose the best is that choose the best, it's all or none. Either you will get full marks or you will not get any mark. But in true false, you need to know all the possible options, or you should be knowing about all the options which are mentioned over there. Okay. But the advantage will be that if you mark one incorrectly, still you are able to get the number from the other which you marked it correctly. Okay. There is no negative marking. So EDA IC in this way is tricky or different, but it is not like out of the world. It is easy, but it is a little bit different for the people who are doing only choose the best, because it's true false. It has 2 papers. First paper has exclusively basic sciences, like there is pattern of 20 each from physiology, pharmacology, and applied basics. This one measurements, they call measurement. It has monitoring, physics, and basic principles of anesthesia. It has 20 questions each, so and each question has 5 parts. So you have to make all of them true false. So it will become 100 each or 300 marks total. And usually the people are getting around 240 or 250, 230 or 220, around 70% they pass. Okay. I did it in 2015, and I got 80% in both parts. But I will tell you something funny, that if someone has passed FCAI, it is exempted from EDA Part 1. At that time, I didn't know about it. So actually, I was doing it all together, and I did EDA Part 1 as well, and then I appeared in FCI, and I passed at that as well. But actually, I didn't need to appear in EDA Part 1. If I had passed FCI, I can just appear in directly, but I did not know about it. I appeared in EDA Part 1 first, and then I did FCI, and then I appeared in EDA Part 2 as well. But this is a distinction. It is vice versa. If you have FCAI passed, you have exemption from EDA Part 1. And if you have passed EDA, you have exemption from MCAI. You can appear directly in FCI. This is true for the people who are eligible for EDA but not eligible for FCI. I repeat, the people who are eligible to appear in EDA 1 and EDA 2 but not eligible to appear directly in FCAI because they are not exempted from MCAI. If they people do EDA both parts, they will be eligible to appear in FCAI. Okay, and vice versa, if they do MCAI and then they do FCAI, they will be exempted from Part 1 of EDA. Okay, EDA Part 1 they will be exempted. For Pakistan, no exemption. For EDA, you have to appear in both parts. If you have not done FCI, if you have done, because you are eligible for FCI. Okay, if anyone who has done FCPS from Pakistan is eligible to appear directly in FCAI because they have got the eligibility, they have exemption from the MCAI. So the pathway should be FCPS, then FCAI, and then they can appear in EDA Part 2 Viva only. So they will have 3 qualifications. The people from other parts of the world, like Egyptian people or Sudani people, they have also, the Sudani people, they have exemption in Irish Medical Council. They don't need to appear in the Irish exam, just like Pakistani people, they have exemption from press. So whosoever has got a graduation from Pakistan or Sudan after 2009, they are exempted from appearing in press exam, and they can get registration only on the basis of OET or IELTS. They just need to do OET or IELTS and they can get registered with Irish Medical Council. But the big problem which people don't know is that even if you are registered with Irish Medical Council, even if you reach there, you have no future, because you will only work as a registrar, and there is very difficult or very challenging or very, like, it's virtually not possible for a people. Yes, if people like me, for example, if I go there with so much background, even then I will be working as a registrar, and I need to spend there 5 to 6 years and completing their requirement, and only then I will be able to become a consultant. So it's like impossible for the people who don't have any post graduation. They struggle a lot. There will be something like it is like not governed by the college. They will be doing the rotations there at their own, and for rotations they need to be in that hospital. Like, for example, for Ireland, if you need to do some pediatrics, there are only few hospitals which are catering rotation for pediatrics. Similar is true for thoracic. So the people who are unable to get jobs in that hospital, they suffer, and they are not able to finish their rotations in time. They have to work for 6 to 7 years to become a consultant. So the people who are targeting Ireland, it's not a good option. If you have the opportunity to go to UK, that is much better option than Ireland. Okay, for UK, things are a little bit different. For UK, you need to appear, even for now FCPS or MS or any degree, they have to do either PLAB or they have to do either EDA or FCI to get registration to General Medical Council. Okay, and then they can apply jobs over there. The difference between UK and Ireland is that in UK, you have relatively more opportunity to get registered in training program. It's not like that they announce and then they can interview and then they select you. No, it's not like that. It's other way around. You are working there, you have some contacts, you have some reputation over there, and then they will be offering you training. It's not so simple. The other way for other people to become consultant is the equivalence pathway, similar to Ireland, but here a little bit difference is that even for Pakistani people who have done FCPS, it is relatively easier for them to become consultant via this equivalence pathway in UK as compared to Ireland. And another difference is that you have more opportunities, you have more jobs, it's a bigger country. So if someone wants to compare between Ireland and UK, UK is better. Okay. So this is all about FCAI, EDA, and working in UK or Ireland. Some words about FRCA primary and FRCA final. What is the basic difference between Irish, even comparison between Irish exam and UK exam is that Irish exam is more clinical oriented and British exams are more basic oriented. Okay, so FRCA I think is much more difficult than appearing in MCAI or EDA or even FCI. FCI is different because it is clinical. It is but EDA part 1 or even EDA part 2 and MCAI, they are all basic sciences exam. Okay, but these basic sciences exam are on one side and a primary FRCA is on other side. There is some rule, I'm not sure about it, but majority of the people who are in a training program for more than 1 year or 2 years, they can appear in primary FRCA, and if they pass primary FRCA, they can get exemption from PLAB. Okay. Similarly, if someone has passed EDA IC or someone has passed FCAI, they also get exemption from the PLAB. Okay, but the problem is that the primary FRCA is not easy to pass. It's very difficult. It's very basic. Like they will be asking you, for example, if you go towards the level of intra-arterial blood pressure, they will be asking you about Wheatstone bridge. Okay, or if you go to the physical principle, or they are going to the very basic. So it is relative. I'm not saying no, nothing is impossible, but it is relatively much difficult. Then if you have done primary FRCA and then you can get exemption from PLAB, and if you do OET or IELTS, then you can get registered to GMC. The difference between FCAI and FRCA is that if you only have the exemption, you don't need to work in Ireland before you appear in FCI. Like I did not work in Ireland, but I did this FCI exam, and many other people can appear in FCI exam without working actually in Ireland. But in UK, things are different. Even if you have passed FRCA primary, you need to work at least for 1 year in UK before you are eligible to appear in the final part. Okay, final FRCA, you need to have primary FRCA, and then you need to work for 1 year in UK before you can appear in the final part of Royal College of Anesthesia exam, like the FRCA. Okay, so the people who are not planning to go to UK, it is useless to do primary FRCA. You are nothing. Primary FRCA is not a degree. Okay, it's nothing. Okay, so there are some exemptions for primary FRCA. If you have done EDA, then you will have exemption from primary FRCA. If you have done FCAI, then you have exemption from primary FRCA, and then you just need to work 1 year in UK, and then you can appear in final FRCA. Okay, final FRCA though is clinical, but it also has link with basics more than FCI. Like in FCI, you have, for example, if you have 10% of basics in FRCA final, there will be maybe 20 to 30% of basics still, even in final part. Okay, so FRCA, that's why FRCA is relatively difficult as compared to FCA, but nothing is impossible. So if you are coming back to the point of view, FRC also has a similar pattern. Okay, they have SAQs, they have true false, they have choose the best. They have all three combined in both the parts. And then one thing which I have not discussed yet is OSCE, the objective structured clinical assessment examination. Okay, so actually what is OSCE? Some people ask what is OSCE. OSCE is actually you just imagine yourself in preoperative assessment place, in either in clinic or in the OR. You are assessing a patient, or you are in OR and you are dealing with the patient. These two scenarios are actually OSCE. Like in preoperative assessment, you need to counsel a patient, you need to evaluate a patient, you need to tell about some complication, like patient had awareness, now you are dealing with it, or patient had awareness in the previous surgery. This is OSCE. If patient, you gave epidural and there was dura puncture and now patient is having PDPH, this is OSCE. Okay, so things like that. Anything which you face in preoperative assessment, you need to evaluate any investigation like X-ray, ECG. You need to evaluate any ABGs. ABGs will also be there in the OR. So in the OR, like anything related to machine, related to monitoring, related to any critical incidents. Like critical incidents meaning, like for example, any complication which occurs, they will be asking you about it in OSCE. Interpretation of investigations like point of care testing like ABGs, this ACT, HemoQ. You are dealing a patient, suddenly bleeding occur, how will you manage? How will you evaluate how much bleeding has been occurred, and how will you optimize the patient, and how will you manage it? So this is OSCE. So there is in primary FRCA, there is also OSCE. There is MCAI, the membership exam part of this MCAI. This also has OSCE. EDA does not have any OSCE, and final FRCA or FCI does not have any OSCE. Okay, so this is what we need to know about this exam. I will take few minutes to tell you about another pathway which people don't know. I have discussed this thing in detail in another session of career counseling. I will try to repeat it, that if you want to have something, you have done fellowship or post-graduation from your country, and now you want to do something extra, or you want to settle in a way that you are having some international exposure, the best way is to do USMLE. Just pass it, just get registration from ECFMG. And now currently the situation is that USMLE, the step 2 clinical part that was called as CSA, is being exempted at the moment, and they are accepting OET. Like you have to do step 1, step 2, OET, and step 3, and you will be registered with the CFMG, and then you will be applying for fellowship. That will be 1 year clinical fellowship, and you will be earning a lot. You will at least be earning around $4,000 to $5,000 in a way that you are able to run, and the advantage which you will be getting is much more than what you are getting. Okay, so if after fellowship you have 2-3 ways. Number one is that if you are good and you are energetic, they may consider you, that it is on the program director. It will be in his hand. He or she can transfer you in the residency. So either you will be transferred to residency and you can do the residency, and people will be having wrinkling in the eyebrow. Oh, we have already been trained, and now why we should do training? Oh, there is no. I don't like America, honestly, but there is no comparison to American training. Even with previous apologies from people who are UK or Irish trained, maybe my experience is not a clear cut way, but the people from whom I have got encountered, if you want me to rate American training, the trained people are the best, and then UK or Ireland. So if you want to have the best in the park, there is no comparison between American training and anything else. And another thing is that the earning of a consultant in America, there is no comparison to that by a consultant working in UK or Ireland. Even if you become, after so much effort, you become consultant, the salary which a consultant in America get it's not comparable. It's much more than people in UK and Ireland. Okay, so now coming back to that thing, that if you have done one fellowship, either you can come back, even then you will have big exposure, and majority of the countries or majority of the hospital, you will get too much respect. This is one thing. Or you will be transferred to the residency pathway, or another, or is that you, after finishing your first fellowship, you have now contacts over there, you can get another fellowship. Like first fellowship you did in obstetric anesthesia, now you do another fellowship in pediatric anesthesia. Then you do another fellowship in perioperative care. For example, I'm just giving you an example. If you did 3 fellowships, you can be registered, you will be considered as you can get some exemption, and you will be registered as a consultant. Because with 1 fellowship, you cannot work as a consultant. But if you have done 3, or in some states 4 fellowships, your future is secured in US now. Now you can work as a consultant, and as I told you, there is no comparison to people who get training in America, the salary, the training, and there is no comparison. Like, I'm much impressed, though I again say prior apologies, and there will be exceptions, that maybe my experience is not the absolute one. Okay, people can challenge this comment, but I say that there is, because I will tell you that in Saudi Arabia, I hardly see. I was working in the best hospital of Saudi Arabia, and I encountered some of the American consultants, and even they left the place because it was not that much attractive for them. But the people who have worked in UK and Ireland, because they are not able to get that much salary, when even if they are consultant, they are not able to work there, because even after so much of hard work, they are not getting a comparable income. Okay, so they move to Gulf areas, and they become consultant, and they don't leave the place till they are being kicked out of this place after retirement. Till that time, they are not leaving this place. So this is a small comparison why people don't want to work as consultant in UK, Ireland. Majority of people, exceptions are always there. But you will see, even in the hospital, very high rated hospital, like one of them in which I worked, King Faisal Hospital, there were few American trained people in anesthesia department, and then they left the place. Some of them went back to America, and some of them they went to UAE, which their salary was much better even from there, from King Faisal. Though King Faisal is the best place in Saudi Arabia, I will rate. Okay, so all the people who want to move forward, I will suggest them, if they are young, if they have energy, they should not waste their time in anything else. Immediately, they should do USMLE, get registration with ECFMG. And even I will tell you something, in this scenario now which we face, if you go to the website of GMC, you will see that if you have done USMLE, that is accepted, that will also give you exemption for PLAB 1. So if you want to go to UK and you don't have any exemption, this is one way. By that way, you can get the exemption from PLAB, and you can just appear in PLAB 2 and get registration with GMC. So that way you will have both doors open. If you want to go to US, you can go there, and this is an interim arrangement as well, that you do step 1, step 2, and then PLAB 2. OET is a common thing. Get registration with ECFMG, get registration with GMC. Start working in UK and start trying for fellowship. Immediately, as soon as you get the fellowship, you go to US. This is the best way, believe me. If you want to have the career, I have passed through that phase. There was no person to guide us like that. Okay, that's why I am after you people. That's why I am after you people, that I'm requesting all of you to have this information, because I swear nobody guided. No people in UK, Ireland, America bother to tell the people back home in detail. They either encourage to out of context, or they depress out of context. They are not telling you the reality. Okay, there are so many people who go there are not able to become consultant, and there are so many people who become consultant. They are enjoying life, but they are not encouraging other people to come. So again, I'm saying exceptions are always there, but usually anesthesia as a specialty, who is being prime in any part of the world, but gradually as we are passing by time, saturation is occurring. Okay, and saturation for other specialities is not bad, because any physician or surgeon can do something independently, but anesthetist cannot do. Even in our home country, we cannot do anything alone. Okay, we are dependent on others. Okay, so I hope I have clarified a number of things, starting from how you should be focusing or targeting any exam. Please request, target topic in the way I have explained in the earlier part. Another way is that the best way is to read your patient. When whatever case you are doing, there are maybe 10 or 15 sort of surgery you will be doing repeatedly: inguinal hernia, thyroid, laparotomy, cesarean section, or you can make a list. By the way, I have made a list and I share a number of times. If anyone wants it, I can he or she can contact me, and I will tell again. I have just made all the sessions are available on the YouTube, and you can focus it. Anesthesia planning is the one where you will find the common things which you should be focusing. And then there will be no question that I am preparing for FCI. What are the different ways? There is no different way. You have to, I'm sure if you are appearing in EDA, thyroid hormone is supposed to synthesize thyroid hormones. Okay, thyroid gland is supposed to secrete thyroid hormones. It's not secreting aldosterone in FCI exam. Or the pancreas is not secreting cortisol in FCI exam. It's the same. So how can you say that there is something different? If you know that diabetes mellitus, with all the complications, all the effects of insulin, how insulin is controlled, what are the microvascular, macrovascular complications of diabetes, how to interpret them, how to see the extent of autonomic neuropathy or things like that. I have tried to chalk out, and it's available in the link which I share a number of times. I don't think so majority of people have looked into it. It's in the topic wise question folder. You will find these things. I can show at the end to you people. But my message is that whatever exam you are focusing, just try to be logical. Yes, there will be a little bit difference. There will be, in some exam, there will be more of basic sciences, less of clinical sciences, but there is no distinction. Nobody can say that you should not read this thing for that exam because it's not being asked. This is it's very narrow distinction. So if you want to target, just practice like a athlete who is preparing for marathon. If you are prepared for marathon, with little change, you can appear in 100-meter or 200-meter race as well. But if someone has not prepared for marathon and is only running 100-meter race, he cannot run marathon. Okay. So this is my message, that if you want to prepare for any exam, whether it is oral, whether is it MCQs, try to have the baseline knowledge. Try to have that thing which is common for any mode of evaluation. Okay. So that's what I wanted to tell you. Any questions? Any question, please? I will show you the link again in a moment. I have shared this link number of times before. This is the main link, okay? And you will find articles and books in this subfolder, FRCA Mind Max, having all the topics covered. And this is, I was telling you, I'm not able to prepare all the topics, but whatever topics I have prepared, you can have a look and you will find a lot of benefit. Because if you know, will be a window through which you can see the world, okay? So you can find all the topics here. The file which I was showing here was also from this anesthesia plan, okay? And this is for some people, it is attractive, not it's absolute one again. It is just a guide to anesthesia exams. There is a list of, I just try to chalk it out in 150 topics just to make it a little bit attractive, because people like attractive things, okay? But it's not absolute. Again, I say that it's not absolute, but you can find, you can target in that way, and you can have some extra things later on, okay? Then this is the link for articles, okay? All the topics you want to have, any topic, you will find it here. Gynae ops, pediatrics, elderly, okay, cardiac, respiratory, thoracic, all the topics are arranged here. These are latest updates in anesthesia, okay? And this book folder, you will find all the books related to basic sciences, review books. This is, I rate them very important, okay? I have just tried to number them all book. You can take anyone. People are afraid. Some people ask me, oh, so many books, how can we do it? You can start with any book and then you can go on from there, okay? These are some for review books. And I have numbered in each folder where there are more than one book. I have just tried to number them apparently. Maybe you will like this book more than this book, but I have named it one, okay? So this is how it's up to you. All these books are almost same. You can see the year of printing and then you can target. But remember one thing as a whole, because all these books are not very like printed in 2022. Some of them are old. The guidelines, they change, they are updated, okay? So whenever you are reading any book, any article, if there is something related to guidelines, try to find the latest one in the Google, okay? Don't rely on them. Otherwise, pathology now doesn't change. The pattern of any topic doesn't change. Clinical signs, symptoms never change. Investigations usually don't change. Some extra investigation, some interpretation may be updated, but usually they will also not be changed. Association, drug interactions will also not change. So you can rely even in the older stuff, okay? So this has come, the world, like I have mentioned it, MCQs world. It has basic sciences MCQs, best choice MCQs. This is American pattern in which there are both sorts of MCQs for clinical as well as basic sciences, the common books which all of you actually read. This Brian A. Hall or Comprehensive or Lippincott or MGH, all these books are here, okay? And this is basic sciences and clinical sciences. These are usually FRCA books, okay? And these books you need to prepare for if you are appearing in the FRCA or in even FCI. FCI is the same. I read this book. Where is it? These 4 or 5 books I read. This was a relatively new book, which was not there before, okay? These are some questions for regional anesthesia. I will highly rate this book, okay? This book is, I read for 2 diplomas of regional anesthesia, which I did. There are some MCQs book for pain management. This is also for pain management, okay? In this book, only if someone is not preparing for a specific regional anesthesia exam, the only thing which you need to subtract is, because in this book you will find even for one block so many approaches which you don't need if you are appearing in general anesthesia exam. If you only delete this thing, the rest of the things you will find wonderful. I will say that this is one of the best sources if you want to prepare regional anesthesia. It has everything. Even in the other books, you will not find regional anesthesia in a pediatric patient, regional anesthesia in elderly, regional anesthesia in pregnant patient. So you will find these things. And the deficiency of this book is ultrasound. So in this book, I had this hard copy. I took the pictures, scanned them, and I put them here. I did not have the soft copy of this book. This has some ultrasound as well. Okay. So for regional anesthesia, these regional anesthesia MCQs folder, and this is for the people who are appearing in prometric exam for Saudi Arabia or other Gulf countries. It has all the MCQs. This has an ICU MCQs. If someone is appearing in EDIC, EDIC, okay, or any part of like any ICU exam, it has some MCQs like that. Okay. And these have the books which people to use to remain away as much as possible, because this is one of the most terrible book which people read, and actually it's a disaster. If someone in 2022 is trying to read this bloody book, I'm sorry, he is terribly wrong. Okay, because with passage of time things change. Average student cannot swallow this book. People read Morgan, it's a disaster. Morgan is one of the most terrible curse on all anesthesia residents, because this is a book in which the title should be catch me if you can. Catch me if you can. Okay, and the people who are being endorsed to read this book always say this: oh my dear, you will not be able to understand in first reading. You will have to do multiple readings 4 or 5 times, then you will be able to understand. And there are so pity people who believe on this thing, and still they are having this curse going on. And I give you another evidence. Majority people, medical college, medical students, they never read Lang series books. But unfortunately, somehow it's thrown in the minds of the people that Morgan is the teachers read from Morgan, paper comes from Morgan, and if you don't read Morgan, you will never be able to pass. You see, I read Morgan and I pass in 1976, and now you are in 2020, so you have to follow me. This is what our people do, unfortunately. And if you ask a woman to go in the kitchen and have a smash in a pot rather than using a chopper, that lady will be looking at you like a damn fool. What are you asking? If someone is asking to use stove to warm the food rather than microwave oven, who will be using stove to warm the food in era of 2022 when you have microwave oven? These books are, believe me, just like that. If you want to have updated knowledge, you have to come out of it. Lang series books are terrible. Lang series books, Harper, Katzung, Genong, clinical microbiology, clinical pathology, RJ Last, which majority of these books never ever an ordinary medical student read. So somehow, how Lang series book can be a book for the most important part of your career? It's ridiculous, believe me. So please come out of it. I have kept them because people are not happy without Morgan. Okay. This book, even the people who are now studying this MCQs, they are not looking at it, but I will request you to have a look. There are this CRQs books, 3 CRQs books as well, and the other books are SAQs. Okay, so you should practice. You don't need to read all the answers in detail, but for the practice, you should at least be knowing what are the questions being asked, so you will have a knowledge about them. Okay, and the people who are appearing in FCAI now, you should be reading all of them. Okay, and you don't need to read each and every line of these books. You just have to look at the question and try to figure out the answer, and then just compare it. Okay, so please, the people who are happy to cram the MCQs pool for their exam, I humbly request them, even if not being asked in their exam now, they should not leave them. Okay, they should read from these books. Okay, and I have just put some SAQs pool from the previous exams. It's there. Okay, you can have a look on it. These actually are from Hong Kong College of Anesthesia, but this is very good for practice. Okay, and I forgot to show you here. In here, topic wise questions also has SAQs topic wise and solved SAQs pool. There was a website who used to print the question, and I don't want anything in return, but just have a look. It is not prepared like that. I copied from the website, arranged them in folders, and alhamdulillah, nobody looks at it. This is the best part of it, because you don't have time. Okay, and I think that I'm the only person in the world who has time. No, all other people are busy except me. I don't have job, I don't have family, I don't have anything else to do than to running behind you people. Okay. So I think I will finish our talk, and if anyone wants to ask anything else, if any of my comments are hurting to anyone, I apologize. And but it's a reality. A reality cannot be changed. Okay. So this link I share with everyone. There is another link which I have made. It has article. This is articles topic wise, and another link I have made with anesthesia tutorial of the week, and this BJA education to date up to 2021, end of 2021, and another anesthesia in critical care series I have arranged year wise as well. I shared that link yesterday as well, and with the name of Articles World. You can find it here. I think I send it. This is the link. Okay. This has year wise. It has year wise in 3 forms. These are articles from the source which I told. I exactly don't know the name of it. Okay. You just look at it's not done by any of my assistant. It's been done by myself. Okay. So this is one of them. Okay. Year wise, this has all the anesthesia tutorial of the weeks up to now. Okay. And this has BJ education. Its name was before CEA-CCP, continued education in anesthesia, critical care and pain, and now its name is BJ education. Okay. And then people ask after all the discussion, sir, but please tell what should be the base book. And I really wish to hit my head to any of thing around me, because if you are reading these articles, I guarantee you there is no need for reading or cramming or worshipping any specific book. You can look anything from them, but no need to worship, have multiple readings. You just should be looking at these articles, trying to extract the knowledge, information, make them in points, make your notes, and then throw it away. You don't need to worship these articles as well. And actually, it's not possible to read all of them, because some of the articles may be printed in 2001, but in 2012 or 13 or 14, the same topic will be there. So you just have to choose the latest one. Okay. So you will find all the articles here, ATU2 and BJ education. This link I share multiple times. I can share to anyone who wants to use them. Okay. Arsalan, yes, you please, before we finish, you can tell your question and then we will finish. Or anyone wants to ask any question, please.
Yes, sir. I just wanna say, if we study from different book, how can we summarize it? At the end, you answer it as well by giving by telling about the article. Or this is what I want.
Yeah, because in the exam, you don't need to do as a witness or say on a holy book that I, Arsalan Khalid, read and cram and ratify Morgan Sharif, Manhus Morgan Sharif 10 times. You don't need to do this. Then why you are worried? In the exam, you are being asked a task and you have to answer it. And there is no compulsion on you that you have to tell it from a specific part of a specific book. Actually, the problem is that you people don't have the vision correct. And unfortunately, you follow the immediate seniors. And those immediate seniors, among them, the person who passed the exam in the first attempt is the most respected for you. Oh my God, he passed the exam in the first attempt. And believe me, he is the most dangerous person, because he has not seen the gravity. I am in front of you. I passed my exam in last attempt. with so much tension, eating beta blockers for 1.5 years. Okay, so as much as I have suffered, nobody else. People used to think that I am from some other planet. I'm not from Pakistan and I don't know what are the realities there. People, sir, I am busy in my job. I cannot attend your lecture. Sir, I am busy with my family. I cannot attend your lecture. Sir, I read it from Morgan, but I don't know the answer, but I will still read from Morgan. That's the comments which I get from people. Say that if you don't read Morgan, you will fail. So you see, I can only push you people. At the end of the day, I have no interest. I don't take any financial benefits from you, any administrative benefit from you. I am not in Pakistan. I am not in that teaching setup. I'd have no conflict of interest. I am not humiliating anyone. I have nothing to do with anyone else. But yes, in my opinion, all the people who are not teaching you or all the supervisors who are not taking pain of you are unfortunately should be thinking what they are doing. Okay. And if, for example, they are not realizing this thing, you should become a very sticky, like a leech. You should be asking questions to them. Okay. This is the only way by which you can change your scenario a little bit. Okay. So I think I will finish on this note. Anyone wants to ask any other question? All are silent. Either you have understood everything or not understood anything. What should I think? People from different part of the world are here. Vijaya, Kumari, Kevin, Dr. Ahmed, okay, Bisham, Himnani, Amir, Abu Zikri, okay. I hope I have given.
Thank you.
Yes, Dr. Ahmed, I would like to listen some words from someone else than Pakistani. Please go ahead.
Okay.
What did you understand? Okay, everybody, I think I have taken a lot of time, and you all are welcome to ask anything later on as well. Okay, the recording will be available on YouTube, and I finish the session now. Okay, see you. Assalamu alaikum.